Hi classmates, my name is Cheryl Harrison. I am a DNP candidate at the University of South Alabama College of Nursing. I am presenting my project slides on implementation of a second victim program and peer support training. Dr. Albert Wu defined the second victim and identified this phenomenon in healthcare personnel. The second victim phenomenon is characterized by lingering emotional stress long after the occurrence of an adverse clinical event or medical error. The need for a second victim support program at Memorial Medical Center in Springfield was supported by the following three questions. Those involved in an adverse clinical event within the past year, 29% responded yes. 88% of those responded yes that MMC would benefit from a second victim program. In a survey of July 2017 by the nursing department, 40% responded yes that they developed a fear of the future after having an adverse event. The Second Victim Program Planning Committee kicked off in October 2017 and was attended by 45 organizational members. The Planning Committee meeting started in January 2018 with 20 members. Departments represented were nursing, diagnostic imaging, pharmacy, respiratory therapy, human resources, employee assistance, patient quality and safety, pastoral care, organizational development, nursing education, laboratory, and communications and marketing. The Second Victim Peer Support Program has one aim and three goals. The aim is to provide support at the department unit level and aligns with the Institute for Healthcare Improvement fourth aim of caring for the caregiver. Program goals include going live within 6 months after the start of planning in June 2018, complete peer support training for 36 individuals before June 2018, and develop a contact process and electronic program documentation forms before June 2018. The second victim recovery trajectory has 6 stages and was identified by Scott. The first stage is chaos and accident response. Intrusive reflections is the second stage. Restoring personal integrity is the third stage. The fourth stage is enduring the Inquisition. The fifth stage is obtaining emotional first aid. The sixth stage of moving on has 3 outcomes. Thriving involves individuals who learn from the event, use it constructively, and improve their practice. Surviving involves those individuals who come to work, but they remain somewhat disengaged and no longer interested in advancing their career. Dropping out involves those who consider or do leave the field or taking a job markedly different from the one that the individual has now. 3 levels of peer support were defined by Scott. Departmental unit-based support at level 1. These are fellow staff members who provide emotional first aid and are able to identify second victims. Trained support is level 2. These individuals provide emotional first aid and supportive encounters and help expedite referral to professional mental health providers if needed. The third level is professionally trained mental health providers. These include employee assistants, pastoral care, mental health NPs, psychologists, psychiatrists, and social workers. Some events are out of scope of the second victim support program. Peer supporters should not be engaged in cases of workplace violence, any act of threat of physical violence, harassment, intimidation, or other threatening, disruptive behavior that occurs at the worksite. Also, personal or traumatic events should be referred to employee assistance. The supportive interaction has 4 key elements and was developed by Scott. The first key element is the introduction. introducing the goal of the second victim program, and listening and supporting. The second key element involves exploration and uses open-end questions such as how do you feel about what happened? The third key element is informing or information and validating a normal reaction to an abnormal event and providing contact and self-care information. The fourth key element involves follow-up, which would be an additional visit or referral to employee assistance if needed. The population for the second victim peer support training was a sample size of 36 employees at Memorial Medical Center in Springfield, Illinois, a 500-bed Level 1 trauma center and teaching hospital. The organizational membership of the group was 31 in leadership positions, 3 in staff positions, and 2 did not indicate any particular position. Departments represented were nursing, diagnostic imaging, pharmacy, respiratory therapy, human resources, employee assistance, patient quality and safety, pastoral care, organizational development, nursing education, laboratory, and communications and marketing. Components of the peer support training course included a computer-based learning module in HealthStream taken prior to the course, covering the introduction and background of the second victim program, the 6-stage trajectory, 3 levels of peer support, and the 4-part supportive intervention. The classroom lecture covered a review of the CBL format, program logistics, orientation to simulation instructions for logging into the closed-circuit video recording system, and 3 video recorded encounters with standardized patients. The 3 scenarios included a peer-to-peer, manager to employee, and peer needing referral to a professional mental health provider. Accessing trained support at MMC involves one of 2 ways. The individual may call 788-4000, leave a voicemail, and the call will be returned the next business day by a member of the Support for Second Victims triage team. The Support for Second Victim triage team member will complete intake information and arrange connection with a trained supporter. Also, completing an online form on Memorial Central at Initiative Support for Second Victims, submitting a request, and a member of the Support for Second Victims triage team will call the next business day. The Support for Second Victim triage team member will complete the intake and arrange connection with a trained supporter. Results of the program were the following. The course evaluation summary showed 95% gave the course an overall excellent rating, 89% of the participants would recommend the course, and 95% felt confident providing a supportive encounter. 35 completed the course, 1 dropped from the program. The course was reduced from 1 day to a half a day. The manager-employee scenario was eliminated based on conflict of interest and a problem with confidentiality. Portions of the lecture covered in the CBL were also omitted. The CBL was reduced from 62 to 34 slides. Slides with titles or graphics only were eliminated, which decreased the viewing time to under 1 hour. From June till October 2018, there have been a total of 6 encounters completed. In conclusion, the course received an excellent rating by 95% of the participants, and 89% would recommend the course. Recruiting more staff members for peer supporters would be advantageous. 31 out of 36 were leaders, and staff level are usually in direct care or at the sharp end. Reducing the course time to 1/2 day allows scheduling more courses and may increase the number of supporters. The second victim programs improve the perception of employees that the organization is concerned about their emotional well-being. Also, the organization should consider additional in-house marketing such as road shows for increasing program awareness and utilization for sustaining the program. This concludes my presentation. Thank you for listening.